Hi, my name is Carla Sumala, and I, along with my colleague Andrew Broderick, serve as project directors for the SF Tech Council. The Tech Council, which officially launched in 2015, was formed to advance digital inclusion for older adults and people with disabilities in San Francisco. It's actually the first organization of its kind in the United States. Today, the Tech Council membership includes leaders from over 25 private businesses, city agencies, and community-based organizations, as well as from academia, philanthropy, and healthcare. In addition, we have a wide network of friends and supporters throughout the city. Thank you for joining us today. At our May 20th meeting, Sabra Matovsky, Chief Executive Officer of the San Francisco Community Clinic Consortium, and Courtney Lyles and Elaine Kung from the UCSF Center for Vulnerable Populations joined us to talk about how COVID-19 is pushing us to expand services digitally. This part of the meeting was hosted by SFTC co-chair Ann Hinton.
So I was just
Okay.
Are you relatively new to the consortium, or have you been there for a while?
I've been in this position for about 2.5 years.
Aha.
The previous CEO of the consortia had been there for about 23 years.
Yes,
so,
that's right. Yeah, and I think that's who some of us on this in this meeting know. So I wasn't there when you came on, so I welcome you to your position. And I'm hoping you can give us a little of a background on the consortium itself, but also to say that you're today with us because you're going to be talking about your COVID-19 strategies. Is that correct?
Correct. Yeah.
I think that we have a visual, a presentation that others.
I didn't do a full presentation. I think the second presenter is going to do a presentation. Mine is a little more of a crash course on what we've been doing for COVID-19, and so I didn't prepare slides for that, but I'm happy to talk people through our work.
That sounds great.
So just as a general background, the consortia has been around. This will be our 38th year in operation, and it was formed by our member health centers to be a central support organization for them. So we do things with technical assistance and training, sharing best practices, advocacy and health policy, those types of things with our health centers. And over time, our work is branched into doing more quality improvement types of activities or joint trainings on motivational interviewing or all sorts of things that we work on with our health centers. We're not an IPA or a medical group. Some people think sometimes that we are, but we're more of a advocacy and technical assistance organization for our members. So we have 11 health centers. About 2/3 of them get some form of federal funding. And if you get federal funding, you have a very specific scope of work that you've agreed to do for the federal government. And it's usually for a very specific population that has health disparities and is in a low-income neighborhood or has known issues with their health care. So many of our community health centers, all of the ones that are federally funded certainly, have a target of deliverables and a population to serve on behalf of the federal government. So for instance, there's a Native American health center. South of Market works on African American and Black issues. We have Mission Neighborhood. We have Northeast Medical Services. All of them are targeting very specific populations and very specific health issues that those populations are prone to. So it makes for a very diverse group in terms of what they're doing, but there are some commonalities and themes that run across all of our members. And so that's really where the consortia comes in to assist with some of those shared needs across the group. One other thing that I wanted to share is that we are also the Healthcare for the Homeless recipient in terms of federal funds. And we do have an outreach van that does go out and does direct street medicine for people who are experiencing homelessness in San Francisco. So that's another piece of what we do. I was asked to speak about what's going on with COVID-19 and the health centers. I have to say that it was a very quick pivot for the health centers to move from face-to-face visits, which is a federal requirement for payment, that we do face-to-face visits. They haven't paid us with any of the federal funding for telephonic or telehealth type visits. So as you can imagine, the shelter-in-place orders and the move to telehealth has been a seismic shift for our health centers in terms of standing up that type of service, given that it has not been payable in the past for us. It is now because there is an emergency health order in place. However, the funding for us in terms of telehealth is limited at the moment to the scope of the emergency order, the emergency declaration. We are doing advocacy to try and extend that technology and opportunity into the future. But right now, that is not a permanent situation for us as much as we would like it to be. So just want to share that. Some of my conversation with Andrew was also about, our health centers' use and our patients' use of portals and other technology. And I just wanted to share that we have some unique challenges. We have Northeast Medical Services that sees mostly a Chinese population, and they use NextGen, and NextGen is only available in English and Spanish. So 70% of their patients are monolingual and either Cantonese or Mandarin, so they don't have any real use for their portal that's in English and Spanish. A number of our other health centers also have portals, but our patients go on to Zuckerberg General Hospital and go on to other healthcare facilities where our clinics just do the primary care component. So anyone who goes into our portal would only see their primary care services. They wouldn't see a full array of their specialty visits and their labs and everything else that happens. So we haven't invested a huge amount of funding into the portals, just because after you convince everyone to get on and they only see their primary care in there, it's kind of a less than complete picture that most people would be expecting when they log in to look at their medical records. So those are just some of the things that I would want to mention about care. In terms of COVID-19, we have shifted most of our services to telehealth. For Medi-Cal, you can get paid for a telephone visit for your full federal rate. For Medicare, it has to be telephone plus video in order to get your full federal funding. You can get some portion of it, but to get your full federal funding, it has to include video, which has really been a challenge for our health centers that serve seniors to be able to get the video component. What our health center patients are saying is that it's a lot easier and doesn't have the same data requirements, doesn't have the same technology requirement to just do a phone call, and they're not always convinced that the added benefit of video is worth the time and effort and expense to put in place. So we're kind of learning some things as we go along with them. Definitely telehealth has been a real lifesaver for us in terms of being able to stay connected with our patients and us being able to stand up these types of services has been critical to staying connected with some very vulnerable patient populations that we serve. It's been a bit mixed in terms of our experience with telehealth. We have definitely seen a reduction in no-shows. We have patients who really like telehealth for behavioral health, which is something we haven't been able to offer in the past. However, sometimes our patients live in very cramped situations where they've got, multiple family members, and sometimes that family member might actually be a cause of some of that mental health stress. And being able to have frank conversations about what's happening in the home is not always easy when they're needing, a private place to have a private conversation. So that is definitely happening. But in general, we have been able to connect with our patients through telehealth. Although it varies health center to health center, not every ethnic group that we work with has had an equal receptivity to phone visits or video visits. I'm hearing from Northeast Medical Services that their Asian populations are a little bit less keen on telephone or video visits, that it's not a medium that they appreciate so much. We've been working on standing up best practices and helping the health centers navigate how to do a video visit and how to prep for a video visit or a phone visit to make sure that we collect all of the needed patient information in a pre-call with an MA, and that we do all the follow-up with connections to resources for food, housing assistance, anything else we can provide our patients with as we're having these phone calls, because a lot of them are really struggling. There are different things available for immigrant populations and different resources that we can direct them to. So we've spent a lot of time trying to collect that information to make it available to the patients we serve. We've also applied for grants. We've applied for the FCC grant to try and increase our infrastructure. We don't know if we're going to be a recipient of that grant or not, but we're hopeful. We're also doing a lot of advocacy to try and make some of the changes that we've benefited from being able to do telephone and video visits. We'd like to make that permanent. There is some concern with the state of the California budget that anything that might increase costs or anything that might be an opportunity to reduce costs might be viewed through that lens, just because the state is in such a terrible position right now with the budget. So we plan to do significant advocacy on trying to make these changes permanent. And then we've been directing our health centers to a lot of technical assistance and training. Now that our world is going more virtual, how do we get back to doing some of the screening and preventive care that health centers are known for? And what really is the best way to deliver that care in a virtual setting? So there's been a lot of work with, how to do care for diabetics, how to do care for hypertensives, through video. And some of the equipment that we've hoped to get through the FCC grant, includes some remote monitoring and those types of services. So that's kind of just a quick overview of what we're doing. And I did see there were some questions. I wasn't sure how many of them were directed at me, but let me look at the chat box. Are there any questions in person from anyone?
Yeah, there was one question in particular. Have you served any folks who are deaf or need ASL interpreter services during these kind of virtual or telephonic encounters? Just wondering how
it hasn't been something that the health centers have relayed back to me as a specific issue or problem for them. It is possible that they have, and I can certainly ask them, who they've connected with. But usually I would rely on them to report to me that they've got an issue or problem with something, and then we at the consortia would go out looking for a solution to whatever they're experiencing. But they haven't voiced that as being a specific issue of concern. But I can ask it if they've had deaf or patients needing ASL services.
Okay, thank you, Sabra. So Anne, back to you.
So I had a question as well. Are you thinking that in the future, if there's an after COVID-19, that this ability to bill and do the virtual visits is going to hold? What
we say in the community health center world is that it's really hard to put the toothpaste back in the tube, once you've started allowing patients to do video visits. But it is going to take advocacy on our part to make that happen at the state level. So that's a piece of, we start our advocacy next week with the California budget, and we'll be, that's one of our top 2 issues, is trying to make these changes permanent. So more to come on that. We're a little scared because there are an awful lot of asks of the governor with a very tight checkbook. Sure. Coming up.
Yeah. We have one other question here. The question is from Lana. You mentioned how people from some ethnic communities seem to be less enthusiastic about this model. Are there any plans for health promotion which targets these communities and addresses their concerns? And then we're going to move from this to Courtney, but would you, if you could answer that, that would be great.
Sure. Definitely with our Asian Health Center, they're doing a lot more work to try and reach out to people to make sure that they're comfortable with phone visits or video visits. We are starting to do some more visits in person for needed services or missed services, and that is also an opportunity for a provider that the patient trusts to have a conversation with them about how about we check in with a video call or check in with a phone call next time or in between this visit and your next visit, to start trying to get them a little bit more comfortable with the technology. You know, when we can kind of intersperse video visits or phone visits with in-person to maybe move that person's comfort level.
Got it. Got it. It's been, I've seen it personally in action, and it actually has been terrific in many, many ways. But I can also see that if people aren't comfortable, that could be a problem. So I think we're going to move on because we're going to start running out of time here a little bit. We have two speakers, but Courtney, I think that you're going to go first. Courtney is with UCSF and is an associate professor of medicine there, and is going to share their experiences with the similar kinds of things, their COVID-19 strategies, and the resources that UCSF has developed to support the safety net for providers' efforts to expand virtual care services and to address the digital divide. So it's a pleasure to have you with us today. And Courtney, I think you're starting, and then Elaine, or do I have that backwards?
I think we're both going to go together. Elaine's probably going to go first, but
okay. Okay, well, Elaine, you're an associate professor as well at the UCSF School of Medicine. Is that correct?
Assistant, but yes, you know,
sorry,
largely the same. No,
yeah.
no.
Go ahead.
Yeah,
perfect.
and I would want to say one thing, Elaine, real quick, and then just that we had some slides. I think we're open to questions. Obviously, I think what Sabra, what you just presented was great. Elaine's a clinician and I'm a PhD researcher, so Elaine was going to give you some on the ground perspective care about what it's been like, and then we've worked on other things moving forward and how to actually hopefully partner with more of you to make sure that we in the healthcare community can advocate for broadband device ownership, all the things that the Tech Council and all of you are together, because now it's been a health issue. I've been trying to say this for a long time. I know many of you, but trying to maybe do it more collectively in the future. So take it away, Elaine.
Thank you.
Great. Thanks so much for having me today. Just to give you a little bit of background, I'm a general internist at UCSF professor, but I clinically practice actually at San Francisco General Hospital. And so what we're hoping to cover today a little bit is just sort of how things have changed on the ground, and Sabra did a great job of covering it, so I might just fly through some parts of that. And then I'll share a little bit some of the challenges from like a clinician perspective and a health system perspective, and then turn it over to Courtney to think about some of the patient-facing challenges and then solutions and sort of resources for how we can overcome some of these difficulties. So we can go to the next slide. So I think, you know, when I think about how care has changed, I sort of put it into two buckets. One is thinking about how care has changed between like patients and clinicians. And I think there's been a lot of focus on that. But I also want to cover a little bit later on about how care has changed between clinicians and sort of the other members of the team. So I think the biggest thing, of course, that's been most obvious is that we've really moved on to remote care. So if you can go ahead and next. So this is a paper that came out in the middle of or the end of March. And just to give you an example, so basically when people initially switched over into telehealth, there's actually a huge drop off in their visits as clinicians and health systems are trying to figure out how to make this work. And you can sort of see the data here that was presented in this clinic based out of Boston, but it's pretty similar in our clinic. There's a huge drop off in the number of appointments and the frequency of appointments. And I think something else that we also noticed is, if you can go ahead and click to the next slide, is there's been a change in actually the type of patients that were accessing care. And so this data, it comes over from UCSF, and you know, beforehand, certain types of patients, and we were worried that as we shifted over to telehealth, there might be, you know, Older patients might have greater difficulties accessing care, patients who have non-English preference, really patients where we know that there's a digital divide. And that's largely the case with these data. I think big thing to know is that UCSF was moving primarily to video visits. And with phone visits, there of course are still some challenges, but that the challenges may be a little bit different. But I think these are sort of things that we're thinking about is the type of visits people are having and who's accessing that care. If you don't mind going over to the next slide. And then, sorry, one more click. I think in addition to thinking about how the visits have changed, we've also thought a lot more about remote monitoring, and Sabra has sort of mentioned this. But one of the big things is certainly I think in our health system, especially with like a lot of our patients with digital literacy challenges, you know, as we're managing diabetes, hypertension, we actually don't know what's going on with their care. And it's been difficult because one, you know, using some of these medical devices can be difficult. And then two, actually reimbursement for these devices has been difficult. And so depending on the patient's insurance, we may or may not actually have access to information about how they're doing clinically. And I think the other thing to bring up too is patient portal. So as similar to Sabra, you know, our patient portal is only in English and Spanish. And in our clinic, about 20–25% of our patients are monolingual Chinese speaking. And so the portal is really hard for them to use. It might be able to be used by their children, but there's sort of like all this paperwork involved with getting proxy access that isn't possible when we're not seeing patients actually in person. I think the other thing to really mention that I've really noticed as a clinician is that, you know, we have moved towards a model of in-person care where it's really a lot of team-based care. So, you know, somebody else checks in the patient, they get their vitals done, I'll see the patient, do the clinical care, and then I may refer to like a social worker or pharmacist, a nurse or nutritionist that really help me give wraparound care. And now that people are no longer in the clinic as much, it's actually really hard to think about team-based care in that way. And so actually, you know, when I'm doing video visits right now, actually I am sort of manually go into Zoom. I have to check the patient in myself, not only through Zoom, but also through the EHR. And so that aspect of team-based care has changed quite a bit. And I think is something that patients probably also notice as well. And then I think the other thing too is just since we're not co-located as much, you know, oftentimes when I have clinical questions, I'll ask some more senior colleagues, and that opportunity is lost, sort of with us shifting away from in-person care. So you can go ahead and click to the next slide. And you can just go ahead and click through. So I think a couple of challenges I just want to highlight. I think the first thing is that, you know, there's a ton of patient-facing challenges, but sort of on a clinician health system standpoint, I think clinicians are certainly feeling sort of some burnout in terms of like delivering remote care and how to do it effectively. And part of that is that a lot of us haven't been trained on how to deliver telemedicine care and how to ensure we're actually delivering high quality care. And so, you know, when you don't feel comfortable with the quality of care that you're giving, that is sort of another recipe for burnout. I think the second thing to really think about that a lot of people have highlighted is what does it mean to be patient-centered right now? So I think some of my patients are certainly happy they don't have to come into the hospital. That sort of scares them. But I think there's definitely patients who would rather see me in person and who, you know, if they don't have a phone, they actually can't access care the way that we're delivering it right now. And so thinking through like, how do we give her high quality care and ensure that we are able to give patients access to care sort of the right way, whether they want it through a phone or through video or in person, really being thoughtful about that. And then I think the last piece, which is really not entirely in our control, but is something that I think weighs on all of our decisions, is sort of the reimbursement part. So, you know, how do we get, you know, adequately reimbursed for these types of visits so we can continue to offer it? I think there are patients who like these remote visits are actually better for. I know I have patients who live far away or patients who have mobility issues where I've actually had a much easier time reaching out to them now that we've gone into remote care. And so making sure that there's a path for them to continue to be able to access care as we move forward. And then thinking through the digital infrastructure. So we know a lot of patients don't have access to the technology, but that's also the same thing on the patient, on the clinician side. So right now when I do video visits, I use my own phone, I use my own laptop because our clinic isn't really equipped to do video visits. So I'll go ahead and I think turn it over to Courtney.
Yeah, and so I was just going to do a few slides on patient-facing challenges. I think most of these are not new to this group, so I won't spend a ton of time on this. Obviously, for patients to want to access, I mean, to do a phone visit, a phone is a key feature. Obviously, there's still some flip phones out there, but even making sure people know about programs, get a device, if they're eligible for a smartphone through Lifeline or other programs, making sure they actually have the device. When you add on something like a video visit, which I think both Sabra and Elaine touched on, we're probably not doing very many video visits. I would say in the time of COVID, many providers probably would like to see their patient's face if it is secure and private and an opportunity to see them in addition to talking to them. When there is no in-person option, it does feel like video would be best, and video does not work if you don't have a high-speed connection or enough data to do that, or the skills to be able to download an app. And then that's, basics. And I think all of us together probably are trying to advocate better for all of those things right now, and to make sure that some of the programs that are been extended right now could also be extended into the future so that more people have the basics available to them. But in addition, I would say, obviously there's medical information being shared, there are caregivers involved with healthcare, and then there's the connection, like Elaine and Sabra did a great job of talking about, that are additional potential barriers for patients where you want to preserve an in-person relationship and make people feel comfortable about sharing, having a space and also sharing information online that is private and secure. So those are new things to think about. You can go to the next slide. And I think the last thing I wanted to say is we don't know a lot about telemedicine because, like they both shared, we haven't really done it, at least in primary care. We haven't done a ton of video visits before, especially for underserved populations. It's not something we've been reimbursed for at the same level, and so it hasn't been a priority for us. But we have been thinking about patient portal access, which I didn't even plant both of you but both of you talked about patient portals, which is, a way of thinking about how would our patients access the existing information they had online. And that we do have a lot of research on, that all patients are actually really interested in doing digital healthcare tasks. If you survey Medicaid patients or privately insured patients, almost the majority of them, over 70% on any survey I've ever seen, have said that they want to be able to do those things. There, of course, are barriers in patient portal access before telemedicine was in place by all of the things that this group wants to focus on, people who don't have the phones and the broadband, and then also who might have limited English proficiency or other barriers that might keep them from having the tools and the ability to engage with these services. And in here, these are some of just the highlights of the research. If it's of interest to any of you, happy to share any more, but just the idea that you have to understand how digital fits into your in-person care. And eventually with COVID, we'll go back to some in-person care. And if we're going to continue it moving forward, I think we need to understand to communicate to patients that we do want their relationship to be preserved, and that digital is a way to enhance that, not take away how to do them together. They have to perceive a need to want to check in outside of in-person visits. I think maybe the silver lining of COVID is that there is a lot of need out there, and people need to try to interact with their healthcare provider. And there's not the in-person right now in the same way that there was, and so there's more interest potentially in trying things out than there was even a few months ago. And then, of course, you need to be able to call somebody with technical support or get ability if you can't get in with your password, or if you've got things. We probably don't have nearly enough of that in healthcare to make people feel supported, and that's been shown. And then, like I mentioned, people who don't speak English, and if we only have services in certain languages, that's a big barrier, not to mention the jargon that we can tend to use in healthcare. So making sure that we use interpreters effectively through digital, we remove the jargon, we make it accessible for patients and not too overwhelming. And I think I just have one or two more slides. So I think, I won't hammer this one home. I think really we want ongoing reimbursement for this. I think if we're going to try it now and learn a lot, we're going to redo workflows to try to deliver virtual care. In the time of COVID, we don't want to go back. I would say most people actually feel that way. Even providers who might have been more resistant to it in the past feel like they want to at least keep it moving or have it be an option for them, and need it to be reimbursed at the same rate. We need the other things like broadband and device ownership, and then we need to, of course, have better training for our patients and better assistance for them. And that's where I think we can do a better job in the healthcare system, partnering with many of you on the Tech Council to refer our patients out for digital literacy classes or help with signing up for a program. Right now, we refer out for a lot of other things like housing and food resources. And I think we could probably come up with a better program to refer out for digital literacy support if I had my wish to be able to do some of this in the future.
The presentation that we had earlier fits so well with this. I'm hoping some of the folks from those teams are still on the the line. We do have a question that fits right in with where you were dropping off there, Courtney, and that is, do you well, to either one of you actually, you see a future where things like devices that we're talking about would be part of durable medical equipment?
Oh, I wish. I think that's a tricky one. The problem in this domain, at least from my perspective, has been that it's been too siloed. You know, like the FCC owns this piece and the healthcare agencies own the other piece. And I think the government probably feels from their perspective that they've invested in some of these programs, but we haven't really done a good job, I would say, of connecting across those programs. So it feels to me that like the ancillary devices like home blood pressure monitoring cuffs and things like that, sure, we could maybe get some better coverage, but I think some of the basics we need to be probably leaning on the programs that need more money for the existing programs is my gut feeling for, you know, Lifeline, low cost internet, providers, but that's just my gut feeling on it.
You know, we've seen go ahead, Elaine, sorry.
Oh, no, I was just going to say, you know, I actually, I was drafting a response and then it's easier for me to say it. Yeah, so I think like in terms of access to broadband and Wi-Fi, I think I've heard lots of people sort of say, and I sort of think this as well, is that like we should be thinking about it as a utility, right? Like it needs to be accessible to everybody.
Yes. Yeah.
And I think like, there's a question alluding to like value-based payment and will HMOs pay for devices? I think that is something that like some payers maybe will think about, right? I think there's some payers that have paid for housing, right? Viewing how, you know, housing as a form of healthcare.
Yes,
right?
Right.
It seems unlikely to me that sort of universally every payer is going to do it, but I suspect there are going to be payers who are invested in this, who think of devices in that way and they can think about reimbursing for it.
Yeah. You know, in the